Hi, Assalamu alaikum. Welcome to Iftikhar Talks. I am Dr. Iftikhar. Today we will be discussing use of prophylactic antibiotic in surgical practice. Well, prophylactic antibiotics now have been under use for last more than 30 years to prevent surgical site infection. But there are certain key concepts that we need to understand before we can use this prophylactic antibiotic regime logically. Right? We think there are six key concepts that we need to understand. And the first concept is which wound is actually suitable for use of prophylactic antibiotic regime. Now you understand that the word prophylactic means to prevent. So prophylactic antibiotics are meant to be used where there is really no question of infection, but there's a risk of infection and we want to prevent it. Now from infection point of view, you know that there are 4 classes of wound. The wound can be clean or clean contaminated or contaminated and dirty. So prophylactic antibiotic is meant only for clean contaminated case or some of the clean cases, because clean cases are literally clean. There shouldn't be any use of antibiotic, but we do use prophylactic antibiotics if the risk of infection is absolutely disastrous. So it's a very high risk procedure, for example, like orthopedic implant surgery, or the patient is immune compromised, like a HIV positive patient or renal transplant patient. So the group in which the prophylactic antibiotics are used are those who belong to either clean contaminated group or they belong to clean group, but the procedure is very high risk or the patient is very high risk. If we are talking about a contaminated wound or a dirty wound like a perforated appendix or like a sort of perforated colon or a major spill of gut content during surgery, then the bacterial load is so high that we are not actually preventing the infection, we are treating the infection. So there's no place for prophylactic antibiotic in contaminated and dirty cases. Now the second concept is what antibiotic should be used. Now to understand this concept, please understand that under ideal set of circumstances, when you are using all the standard operating room techniques and you are observing the sterilization protocol, then you are practically excluding all the extrinsic microorganisms. There's no possibility because every technique is being cared for and all precautions are being taken. So external microorganisms and germs cannot get entry into the surgical site. The most likely microorganism which will contaminate the wound are those of patient's own. Right? Now it will depend what sort of procedure is being done. For example, if the patient is undergoing coronary artery bypass grafting, then the only source is when you give skin incision, then the skin microorganisms can go in. But if you are doing, for example, a hysterectomy, then because vagina is open, then vaginal flora will have a chance to get entry into the surgical wound. Or for example, if you are doing gut surgery, then gram-negative as well as anaerobes will have a chance to get entry. So the antibiotic should be chosen according to patient's flora, according to the procedure that is being done. So to elaborate further, for example, if you want to use prophylactic antibiotic in coronary artery bypass grafting surgery, because only skin is involved and the skin microorganisms are sort of getting a chance, so probably a gram-positive cover like cephredine or coamoxiclov should be adequate. But as against that, if you are doing gut surgery, then the most important organism that can get entry into surgical site are anaerobes and gram-negative. So maybe a combination of ceftriaxone and metronidazole will be more appropriate. So this is the concept number 2, that which antibiotic is appropriate for prophylactic antibiotic. So the choice of antibiotic will depend on the procedure and which cavities of the patient will be invaded. So which are the patient's own flora which will be at a risk of getting entry into the surgical site. The third concept is that what is the route that should be used to give these antibiotics. Generally, we want that because these are prophylactic antibiotics, they are already there's no established infection, right? But when the skin incision will be given, or the vaginal cavity or the gut cavity will be opened, then some bacteria may get entry. So the concept is that before that happens, there should be a very high concentration of antibiotic and appropriate antibiotic in the serum, so that whatever few number of bacteria get entry into the surgical area, they should be destroyed immediately. So in general, we want to achieve a very high serum concentration, and the most reliable way to do that is to give antibiotic intravenously. So thereby prophylactic antibiotics standardly are given intravenously, although quinolone group has reasonable bioavailability if given orally, and metronidazole can some centers use per rectally, but except for these two exceptions, as a general principles, the prophylactic antibiotic should be given intravenously. The fourth concept is how much is the dose that should be given for prophylactic purposes. Well, in that case, we want a very high concentration, but still a safe concentration, not a toxic concentration of antibiotic to be present when microorganisms are released into bloodstream, so that there is a very high concentration of antibiotic, and it easily and rapidly kills all the microorganisms swiftly, right? Therefore, try to use the higher side of safe range. For example, if you have chosen ceftriaxone, you can give 500 milligram or you can give 1 gram. Now, because ceftriaxone is a fairly safe antibiotic, it is recommended that you use a higher dose, that is 1 gram, right? Now, the fifth concept to be understood is that what is the timing, at what time the antibiotic should be injected in prophylactic regime, right? Again, as you see, the concept is that we want antibiotic in very high concentration in the serum before the skin incision is given, because we want that serum is laden with antibiotic, and when I give skin incision and whatever 5, 10, 8, 20 or 1000 microorganisms are released into the surgical area, immediately antibiotics look after that. So I want the highest concentration of drug in the serum just before incision. But the problem is, when I'm giving incision, patient is already under anesthesia. It means that theoretically the antibiotic should be given just before incision, because you are giving it intravenously, so it will instantaneously achieve the highest blood level, and after some time it will start dropping. But the problem is, because patient is under anesthesia, and if I give antibiotic under anesthesia while the patient is under anesthesia, then the initial signs of prophylaxis, if there are any, they are masked, and the anesthetist and the surgeon will know about any possible anaphylactic reaction only when there will be changes on the monitor, and that would be too late. Therefore, a reasonable compromise is to give the prophylactic antibiotic dose intravenously just before induction, when patient is awake and can tell about if there's anything is going wrong, the patient is not feeling well, has got a burning sensation up the arm, or is feeling palpitation or hot flushes, which are the normal sort of features of anaphylaxis, or is having breathing difficulty and bronchospasm, etc. So the fifth concept of what is the best timing to give the prophylactic antibiotic dose, then the answer is just before induction, right? And the sixth concept is that how many doses should be given. People have been arguing that only 1 dose is enough, 3 doses is enough, 5 or 7 doses, or you should give antibiotic for 3 days, etc. So various studies have been done. General consensus is that generally only 1 dose of appropriate antibiotic given in appropriate wound, right, intravenously in a high safe dose just before induction is enough. You don't need to repeat doses. So 1 dose regime is as effective as 3 or 5 dose regime. The only exception to that is if the procedure is long, because it is seen that after 2.5 to 3 hours, the half-life of the drug is rapidly approaching and the drug level sort of starts falling. So then after 3 hours, the amount of drug present in the serum is actually less than optimal. Therefore, unless the procedure is very long, generally only 1 dose is enough. But if procedure goes beyond 3 hours, then probably a repeat dose should be given, right? So these were the 6 key concepts about how, when, where, which antibiotic to use and at what time. I hope you liked it, and I hope all the concepts are clear. If you like this video, please like it on your phone or computer as well, and subscribe our channel, Professor Dr. Iftikhar Talks. And yeah, don't forget to press the icon, bell icons. We are loading one medical academic video almost every week, and you will get the notification straight away. Look after yourself and everybody around you, and look after your patients very well. We are with you on that, right? Be Allah with us all. And thank you very much for watching the video. Goodbye. Have a good day. Assalamu alaikum wa rahmatullahi wa barakatuh.